See here, red is the obstetric side. We did a scheduled birth project first, we did a steroid project second, and we're now down here. We're not really here yet. We hope to be here on July 1. This is all pending approval of funding for our project in the upcoming Ohio budget. And you can see what on the NEO side they're working on as well. It's not often mentioned, it's potentially even controversial to say, that prematurity is the leading cause of infant mortality. Bill Callahan, a native of Ohio, who's now the CDC's director for things like that, published this paper from CDC data, and he reached that conclusion by combining all of the prematurity-related causes of death on the death certificate, and if you do that, prematurity beats birth defects by a percentage point or two. So they're basically, essentially, co-leaders. And that's striking because most people think that prematurity has been solved. NICUs take care of all that stuff and steroids, et cetera. And of course we know that that's not the case. So this really we haven't made very much progress, especially for those who suffer the most, the early premature babies before 32 weeks. That's been almost a fixed number that has not budged. But I think we might have an opportunity to move it. When you think about the rate of premature birth in the United States and look at what happened in 2006 when it peaked and why it went down after that, I'd like to be able to say that it was, progesterone or tocolytics or something that we did on the OB side that made that go away. Actually, I don't really know, but I think the best evidence would support that the REI doctors, the reproductive endocrinologists, did most of that by virtue of their change in practice to limit the number of eggs transferred and whatever else they do that I don't understand. The number of higher order multiple gestations, triplets and up, went down a lot. Twins, not so much, but the higher order ones, that's 3 premature babies for every triplet pregnancy. So I think that's probably in the right place at the list of what changed was fertility care, and they did it with a systems approach, a quality improvement about something approach from a medical specialty. We probably, in this community of quality improvers, we paid more attention. The March of Dimes did, ACOG did, AAP, et cetera, to the issue of the scheduled delivery, the late preterm birth and the near-term birth. And that probably accounts for some, and it's possible that progesterone had something to do with that. But I think the remarkable thing here is that it's systems change, the kind of stuff that QI organizations can do. People ask all the time, what are your criteria, excuse me, for picking a project in the Ohio Perinatal Quality? Well, we are a prematurity-related organization, as I mentioned. We are not a maternity improvement, let's improve the rate of postpartum C-section infection or something like that. We are a perinatal, collaborative, PEDS, OB together, and we will pick projects together and work on prematurity and maybe infant mortality. We're talking about maybe we should broaden ourselves into some of the other causes of infant mortality, but really it's prematurity, prematurity, prematurity. So we look for things that are prematurity related, for which there's an existing benchmark and for which there's variation in the application of that benchmark. There needs to be an outcome that's measurable easily. This is not research. The people doing it are not trained research data gatherers. They're everyday hospital folks, docs, nurses, research assistants, data, birth certificate people, and whatnot. So there has to be a measurable outcome that's pretty easy. Ed Donovan has preached that you have to be able to say that you made a change in the state in which you are working. You can't just say, here at Hospital X, our babies do well. You have to be able to say, here at these hospitals, the rate of bad things got better, and there were fewer admissions to the NICU, there were fewer deaths. You ought to be able to look at the state overall if you're a state organization. It's nice to have previous success, somebody you can model yourself after, and that's in fact what we did with the 39-week project. Utah had done it. Pittsburgh had done something like that. Other hospital systems had done things of that nature. We were one of the first, I don't know if we were the first, to do it in a statewide way, but that had been done before. We copied them, and that's great. That's the nice thing about this sort of stuff, is we can learn from each other. One of the things we learned from the selection of the first project, the 39-week project, was that you want to have enthusiasm from the people who are going to join you in this. We were brand new, just like you are, and we weren't quite sure what to pick. We put some options on the table on the OB side, and we thought steroids would be the option chosen because it was pretty obvious, met all these criteria. Variation in use was debatable. Some people thought it was and wasn't. It was. But the enthusiasm for 39 weeks, for scheduled births near term, was incredible. A meeting of about this many people, there was no question that was going to be the topic. Like it or not, that's what we were going to do. I was surprised by it. I really hadn't expected that to even be in the top 2 or 3 of the various things we talked about. It's nice to have public enthusiasm because that can translate into money. And in fact, recently for us, we hope that's the case. So you can see the topics listed, the ones we've done, and the one we're going to talk about. You have to have a benchmark. So if you're thinking about opioid dependence, we've a lot of interest in that in Ohio. We're an opioid dependent state in terms of maternity admissions and in neonatal stays. But how do you fix it? Well, we're waiting for somebody to tell us what to do so we can QI it. Right now, we don't have that. That's probably our most popular next thing. Breastfeeding is happening actually on the neo side. So prematurity it drives the issue of progesterone. And in this case, it's definitely related. There's high variation in practice. Finally, the benchmarks are out. That's what happened last year. ACOG and SMFM published benchmark algorithm type papers. There's a measurable outcome. It's the outcome. The rate of prematurity isn't really even an outcome. It's infant mortality. We'll take rate of prematurity and infant mortality together. If we succeed, we ought to be able to move those numbers. No doubt about population impact. Questionable previous success. I'll show you some slides that suggest that we've had population impact from progesterone. Enthusiasm has been there. And finally, now enthusiasm by our supporters, which is, we hope, will translate very soon into actually this project getting off the ground. So we're preparing for something that we are pretty sure is going to happen. So a brief little excursion into the progesterone literature. When I was a resident in obstetrics and gynecology in 1975, when I started that, there was a paper that had 43 women in it in the New England Journal, lead article in the New England Journal. 23 women got 17P. 22 women got 17P, 21 got placebo, and all the women who got 17P delivered at term, and many of those who got placebo delivered preterm. If you've done any research, you know that's too small, that doesn't make sense, I don't believe it, but we all believed it at the time, so we gave 17P for about 5 or 6 or 7 years until the DES issue came along. Not the same thing at all, but hormone, pregnant, bad, so nobody gave 17P anymore for about a decade of the 80s. In 1990, Mark Kierce, an internationally known obstetrician, looked at all the available literature that had been accumulated previously and kind of called attention to the fact, you know what, this stuff doesn't prevent miscarriage like you guys thought it did, but it does seem to reduce the risk of prematurity. Somebody should do some more studies. And so at that time, soon after that, studies were proposed, and eventually they took many years. In the case of the MEIS trial, this is the MFM network trial that we were part of. Eduardo Fonseca in Brazil did a smaller trial of vaginal progesterone, reported that same year, and they both showed a decline. Now, those studies can be called controversial, but when you get as many studies with arrows going down, you start to think something is actually happening here. This is not a fluke in Brazil by somebody we haven't heard of yet. In fact, that somebody we hadn't heard of did a much larger, better, more robust trial in Europe several years later on vaginal P for women with a short cervix less than 15 millimeters, which is very short, very small number of women. But again, a drop in the rate of spontaneous premature births in singleton pregnancies. The next trial that said the same thing was reported recently, Sonia Hassan and others, a trial that said vaginal progesterone for intermediate lengths are short, but not all the way to 0. Again, a drop in prematurity. A couple of trials, though, stand out, the ones with the little stars here. The vaginal progesterone trial by John O'Brien, sponsored by the manufacturer of the vaginal product, didn't show benefit. So you can look at that, as many people do, and say, well, let's see, here's 17P for women with a history, and here's vaginal down here and here for women with a short cervix. So let's give women with a history 17P and women with a short cervix vaginal. And that's fine. We didn't measure the cervical length in this group of patients. We simply didn't have the equipment and the ability to do that. But we've since learned that women with short cervix are pretty likely to be the women here, and the women here are pretty likely to have short cervix. And that's a population that was 60% African American, that had an index pregnancy delivered at about 32 weeks, and that about a third of whom had more than one previous premature birth. So if you wanted to find women with a short cervix, that is exactly who you would start with. Those are all risk factors for finding short cervix. And in fact, other studies would support that as well. And then interestingly, this trial wanted women with a history because they wanted to mimic this trial to see if vaginal would be effective in that same group. They did not want to have their study confounded by cerclage. So they told the investigators, don't enroll anybody who's likely to get a cerclage. We want women with a history, we want a high-risk population, but if you think they're going to get a stitch, don't do it. And then they measured the cervical length of their patients who were enrolled. And the cervical length at 18 to 22 weeks was 37 millimeters, which is normal, not even close to short. So they enrolled women with a history who had a normal cervix and didn't find benefit. So history really, if you think about it, isn't really an indication. History is a red flag that somebody has a greater than average risk of having the indication, which is probably short cervix. The Groban, or another network trial, the SCAN trial, sort of the same thing. We were part of that one too. And in this trial, the threshold for short was 30. 30 because we wanted to see, gee, 15 millimeter cervix, that only is 3% of the population. It will be hard to find that many women, and we'll never get it done. If we expand it, we will not only do the trial more quickly, we'll also be able to apply this potentially successful intervention to a much larger group of women, more like 10% of nulliparous women. That would be a real advance, so let's broaden the entry. And that's what happened. Most of the women enrolled in that trial had a cervical length above 20, and it turns out that probably cervical lengths below 20 are the ones that would most likely benefit. So when you put all this literature together, it really, in my view, looks like short cervix is the indication. And you can find those women by virtue of their history and by virtue of screening the cervix with ultrasound. The literature on twins and triplets shows no particular benefit. We're not really going to talk about that, but really it can be summarized that progesterone has an effect in singletons with a short cervix, less than 20, and in women who are pretty likely to have a short cervix and didn't have it measured. But it doesn't work if your cervix is longer than 20 or 25. Who knows exactly where the line is? It certainly isn't a fixed number. The point is, short cervix is parturition. Short cervix is not somebody is shorter and somebody else is taller and they're all normal and fine, and the short people have a harder time playing basketball than the tall people, only the game is pregnancy instead of basketball. That's what we used to think. It's pregnancy, you're short, you need a little extra help, we'll give you cerclage or something to make you taller, make you more functional. And those of you who are tall, good for you, you don't have to worry about it. That's not how it works. Short cervix is parturition. So a woman with a short cervix is very likely, but not assured, of getting it even shorter. So measuring it one time early on is a way of finding some women who will go on to deliver early, and others who really, it won't get a whole lot shorter, and the process will just kind of peter out. We don't understand why, but we do understand clearly that short cervix is not some biologic group of people who need help. It in fact is parturition. So if you take what we just looked at and think about how are we going to apply what we've learned about progesterone to a population of women who are likely to have a premature birth. You can break up the groups of women who are eventually going to deliver early into several categories. If you're going to do a scheduled birth initiative, you have to acknowledge that about a quarter of preterm births are a good idea. They're good for the mother, good for the baby, good for both. It's hard sometimes to decide if somebody's in this group, but there's no question that about 1 out of 4, maybe a little higher or lower depending on where you work, is a necessary premature birth that saves lives, either mother or baby or both. There's another bunch in the purple that are multiple gestation, and systems approaches to that are probably the most effective. This is that group. These are the O'Brien babies, so to speak. These are premature births, spontaneous, that is, ruptured membranes, preterm labor, etc., short cervix. Well, not quite short cervix. Ruptured membranes, preterm labor, spontaneous premature births, but not short cervix. They're not progesterone sensitive, according to that study. And then there's this group, and I'm guessing about these relative. This is BPG is ballpark guess. No, that's we don't know. We know this number, and then these are really, we don't know. We also know that of those that have short cervix, whatever the fraction is, it's probably something south of 50%, but we don't really know. Some of these women are progesterone sensitive and some of them aren't. If you take care of women with this history, you'll find that you have opportunities to start progesterone early, often, aggressively. You know, let's dip these women in progesterone at every opportunity, and nothing good happens. Their pregnancies' outcomes are not affected by the progesterone. It simply doesn't seem to work at all. And other women, it changed their life. They have babies that they never could have had before. And in between are a lot of women who have longer pregnancies that lead to living premature babies instead of babies who had no chance. So we don't really know how to find them, but these are the women with short cervix. Again, these are all the women with premature births. So it's probably fair to say that a quarter to half of them have short cervix, and some of those women can be the target of an intervention with progesterone. We really don't know that, and that's what the basic scientist people are trying to figure out. So these, I don't expect you to look at the small print here. These are the two guidelines, the SMFM guideline published in April and the ACOG guideline published in October. They both tell you what to do from different starting points. SMFM says start with all singleton pregnancies up here. ACOG says, what if you happen to find a short cervix? You know, you're walking through the pregnancy woods and there's a woman with a short cervix. What am I going to do? So what they did, it's pretty smart really. I was kind of irked when I saw that, but in fact, nobody really quite knows how to run across a woman with short cervix. So ACOG decided, you know, we don't have enough evidence, so we're not going to pretend that we do. We're just going to say, if you have a patient in front of you with a short cervix, we do have enough evidence to tell you what to do then. And then they in the text that goes with this, they said, you could do it this way or you could do it that way, and basically it's like Group B strep. You can screen everybody or you can screen women with risk factors. And I think, like Group B strep, it's going to be universal that wins, even though it's intellectually doesn't feel right. But screening everybody is perhaps the best way, well, it is the best way for GBS. That's how it worked out. And I think we're going to find it out this way about progesterone the same way we did about GBS. And that is that states or sites or insurance companies, whatever, who use universal will get compared to those who use selective. And maybe there'll be populations where universal doesn't make any sense. I don't know. It'll come from organizations like yours and mine when we report our results, and various people inside your group are going to pick one or the other. Nobody really knows. So what literature do we have to say, let's go ahead? Let's do this. Well, there are a couple of debatable, but definitely highly cited cost-effective analyses. I'm no expert on that, and I don't pretend to get into the details, but Allison Cahill has a good reputation, and Erica Werner also, and do their co-authors at being pretty good at this stuff, and they both came up with different approaches that essentially say, if you make these assumptions, which you might challenge, then this is cost effective. There are a couple of managed care papers from a Medicaid managed care group, Mason et al. And Brad Lucas. This is the same group. This is financial, and this is actual data that looked at women who were prescribed progesterone and found that it helped, and also found, and you can see that I'm using progesterone in ways that offends the purists, because 17P is not really exactly progesterone. But to me, there are ways to give a product that reduces the risk in women with short cervix. So progesterone is going to be what I call it. Anyway, these data suggest that it works in practice. This is data I'll show you in a minute from our clinic, and this is data from Philadelphia that I'll also show you on another slide. This is, to me, the most interesting accidental finding that we've made in our prematurity clinic ever. In 1998, we started a database, and we never were able to use it. I don't know anything about data analysis. I don't know. Excel makes me run away. And Access is even worse. There's a program called Access. We didn't know. Okay, fine, put it in Access. That sounds good. No one could ever get any data out. We spent, but Hetty Walker, who collected all this data, kept doing it. She put a lot in there. It was, okay, we can get it out someday. Well, the someday came not that long ago. So we were able to look back without really knowing what we were going to find. Somebody said, in 1998, in our prematurity clinic, women with singleton pregnancies with a previous premature birth, what was our rate of premature birth in that population as we took care of them then, when we were stitchomaniacs because we had short cervix and we thought cerclage was the right thing, until about 2003 or 4. So these are the rates: 40% before 37 weeks, about 20-some percent, almost 30 before 35 weeks, and about 10% before 32 weeks in this high-risk population. Most of our patients are African American, and most of them have really early premature births. So you notice that when progesterone got introduced here, nothing really happened. That is, 17P started, we prescribed it. Our rates really didn't get much better. You could argue maybe a teeny bit. In 2008, we started a different program to find women at risk of prematurity and get them into care sooner. It was an attempt to try to capture more women in Central Ohio. And by doing that, we ended up seeing these women about a month earlier than we had previously seen them. And it dropped the start date for progesterone from 19 weeks, which is the case before 2008. 18 weeks, 6 days, I think, was our average start date for our population. And after 2008, when we had this alternate pathway to get into our clinic sooner, we saw the women at 8, 10, 12 weeks. We got the progesterone started at about 16, about 15 and a half or so weeks. So it was about 3 weeks sooner. And that's when these rates started to go down and have continued to go down. And we have no other explanation. The population did not get lower risk. It didn't get different. We didn't change anything else. The nurse is the same. The doctor is the same. Everything is the same, except that we started the progesterone sooner. We did add vaginal, so you could argue that somewhere in there that might have been the difference. But in fact, most of our patients actually prefer injections. Some people find that surprising. Most of our patients go, oh, I don't want to do that. Just give me the shot. And that's what we've been doing. So the huge majority, probably 80+% of our patients get 17P. So that's some evidence, not compelling, but certainly interesting evidence. Here's another study of a similar nature. This is a before and after 17P was introduced into the Penn Clinic with Jamie Bastick. No change in the rate of premature birth, but the mean gestational age of the premature babies rose from 31 to 33 weeks, and they had more births after 34 weeks as well. So those are some glimmers of hope, I guess you could say. So we're able at this point to say, you know, things that used to be obstacles are not really. Prematurity is recognized not as something that's been solved, but something that is still here. We have recognition by the FDA that 17P in the form of a manufactured product works. That's good. We have wide support from all sorts of organizations that say progesterone's pretty good. You guys should be doing that more. And hopefully we're over this. We don't know why it happens. We're not sure. It's terrible, isn't it? What are we going to do about it? I don't know. We've been, that's, you know, and besides, isn't it wonderful what they can do in the nursery? You know, and, it's wonderful, but only up to a point. It's not spectacular. It's wonderful. So we can do this, and we've gotten rid of some of this stuff, and it ought to be pretty simple. You just write a prescription for the women who have this, right? Well, as the little example in our clinic shows, no, it takes almost a month from deciding to give a patient progesterone and having the progesterone enter her body. There are that many administrative and intellectual and financial barriers to making it happen. So it's a QI-able thing. So there are lots of questions. There's uncertainty, you know, which agent, which one should I give for which? Vaginal for short cervix, injectable for history is fine, but really I don't think it matters much. How should we find these women? Should they all be screened or not? Everybody? The MFM docs say, yeah, everybody, we'll do it. The generalists say, everybody? You got to be kidding. And somewhere in between, you know, I don't know where the answer is. It probably will be different in different places. How do you actually write the prescription? I was talking to a pediatrician the other day who said, you mean you can't just write the order and it happens? Like it does in my clinic, I write the order for you know, a vaccine. The patient's got it before they leave the building. No, this has to be made up by a pharmacist specially for that, a compounding pharmacist, so you'll have the product in a day if you're lucky, or maybe 3 or 4 or 5 or 7 days. And then they'll be, oh, compounded? Doesn't that give me mold and, you know, aren't I going to die? So I can give Makina, which costs a lot, and even if they say it's free, you still have to go through a lot of paperwork, a lot. We try that once in a while. We don't go there because of that. And so how do you do it? You turn to the ACOG and SMFM, and they don't really tell you how to get over that stuff. Even if you knew how to fix all that, progesterone is an outpatient act. It's not inpatient. It's not hospital. Hospital personnel of all stripes are accustomed to gathering data and presenting it, how many births we had, how many NICU admissions, how many days. They do that in hospitals. We don't do that in clinics. And this is an outpatient intervention that not only has to be recognized and ordered, has to be given again and again and again and again. We're not, I'll tell you right now, we're not going to measure the again and again and again in our QI project. We're going to measure starts, because again and again we would get like, no, we're not doing that. So what do you do for, this is true for any QI project. What do you want to accomplish? What are your goals? What has to change? How will you know that change is an improvement? And can you make it happen? Well, we don't know. We got a big boost when the Ohio Department of Health and the state budget came out recently, the proposal from the governor and the Ohio Department of Health. Part of that had a chapter on infant mortality and preterm births. Strategy number 2, implement and spread quality improvement initiatives via OPQC. We are a freestanding, living on the funds we got from grants organization. We will disappear into the vapors if we don't have any money. And here we are in the governor's budget. He said, does this mean that we're a line item like Tennessee? No, it doesn't. Too bad. But anyway, we're right there, and we're pretty happy about that line. So these strategies, we're going to go through these. There's 5 strategies. We're not going to talk about that. But action step number 5, design, implement, and promote use of progesterone supplementation in high-risk women by Ohio providers. High-risk women will be identified, screened, and treated. You can see the other ones are the things we've already talked about: 39 weeks, the birth certificate improvement, steroids, and human milk. So those are all things that we've worked on. And it looks remarkably like we wrote this. And maybe they copied some stuff from us. We don't know. We can't really say. We kind of think they did. So the charge from the ODH to us is to establish outcome variables and set up a program. So design, implement a program to promote and document the use of progesterone and measure the outcome. So do you have these kind of deals, these key driver diagrams? Everybody know what a key driver diagram is and all that stuff? This is the beginning of the QI cocktail. I learned this on the job. I have no training except what I learned here, and it is a foreign language to me. We're going to go through these, not on this slide, a little bit one by one, but good. I'm glad we don't have to talk about that very much. So here's our overall global aim and smart aim to reduce infant mortality by reducing premature birth. And by July 1st, 2015, we think probably 20% was a little optimistic. That was a guesstimate based on what fraction of premature births might be affected by progesterone. So we put down 20% just because you're supposed to pick an ambitious goal, but we later decided that 10% is pretty ambitious. So I think that's what we're going to use. So here are the key drivers: how to find women who have this history of a previous, really the word spontaneous is not there, in part because it doesn't fit on the slide, but in part also because spontaneous premature birth is not easily distinguished from other kinds of premature birth. So paying attention to somebody who had a premature birth, never mind what you know, it was bleeding. Oh, that's abruption, never mind. No, bleeding is lots of different things. So don't just take the brief description. Investigate before you dismiss the possibility that your patient might be a previous premature birth. Short cervix, progesterone, remove the barriers and track the outcomes. Simple. Not. So when to do this? Well, part of this is informed by our clinic experience. We want to find these women as soon as possible at the first contact. Not wait until it's mid-trimester and somebody says, oh, you need progesterone. Good, we'll write an order and it'll happen a month later, and that could be 24 weeks. This process is going on. The cervix is getting shorter or not, but it's already there in many women as early as 15, 16 weeks and maybe even sooner. So it's sort of an urgent thing to hurry up and do. And then we need to expand the definition of spontaneous. As I said, start looking at everybody. It's not just preterm labor and ruptured membranes, but it's also advanced dilation or cervical insufficiency, whatever you want to call that. And really, it turns out that anything between 16 and 36, especially those 16 to 24 weekers where they're born alive or dead, those are spontaneous births more often than not. Yes, there are birth defects. Yes, there are genetic and medical diseases and uterine anomalies that cause all that stuff, but most of those are spontaneous premature births that happened lickety-split and delivered at 18 weeks instead of 22. At 19 and 6 versus 20 and 1 is an abomination. It is writ in our history, and we will not get rid of it in this generation. But you know, if you're young, you have a lifetime of work ahead of you, and you could do no better than to abolish the 20-week line in terms of thinking about who's having a premature birth and who's not. We are deciding on purpose to ignore the people with the most advanced disease that progresses that quickly. It's as though we said, you have stage 4 cancer. We don't want to include you in our statistics because you have virtually no chance of surviving, so we're going to pretend that the disease doesn't exist when it shows up that way. Only those with stage 3, which we call 20 weeks, will be counted. Those with stage 4, no, it's just a miscarriage. Well, as you can tell, that's my hot button issue and got me off track. So, and I have no argument. I'm not a right-to-life person or a passionate whatever. It's just what we ought to do. If you care about prematurity, you have to look at the woman with a 16, 17-week birth and include her in your program. So that's an argument for universal screening, because selecting out women with these various risk factors can be controversial. Shall we screen all African Americans? The rate is twice as high, almost 1.8. Shall we screen all women who've had fertility care? All women who've had a pregnancy termination or 2 or 3? Those are risk factors that show up. Yes, they are controversial and debatable, but selective means having those conversations when you should be trying to figure out who really needs medicine and getting it to them. So I started out a selective person. As you can see, I'm right before your very eyes, I'm sliding over to the universal side for those kinds of reasons. The algorithm of care, interestingly now, you're QI people, you're not academics. You don't have to worry about the algorithm of care. Somebody else wrote those, and the people you want to influence are the practitioners, and you want them to have an algorithm. You don't want to argue with them about which algorithm. Pick one and follow it. It's okay. ACOG said something, SMFM said something about the same. Put them together however you like. You can't just wait for the patient to come to you. What about this cervical length stuff? Can we just measure the cervix? Let's just go out and measure it. Turns out that's not as easy. It's got lots of steps to it, lots of procedural steps. You have to have an empty bladder. It means you have to have a lot of bathrooms. You have to have probes that are soaked and cleansed that take 15 or 20 minutes to clean between patients. There are ways to get credentialed in how to do it. We won't talk about those right now, but you have to know what you're doing. It's pretty easy to get an erroneous measurement by just pushing a little bit too hard and making the cervical length look normal when in fact it's not. So there are lots of stuff, lots of steps. Most of you probably have seen a transvaginal ultrasound, but in this case, for those who haven't, the mother's feet are this way and the mother's head is over here. The baby's head is, this is a close-up view, of course. Baby's head is right here, and the vaginal probe is in the vagina, just in the front of the cervix. There's a little teeny tip of the bladder, and the internal cervical os is right here, and the external is right there. And this is a great picture. I mean, I took it, so I like it a lot. However, it isn't, it's just one of the few that I took that was great. You have to take 5 to get one good one sometimes. But and this cervix, as you can see, is 2.55 centimeters, 25 millimeters. It's a little on the short side, but otherwise it's a pretty good picture. And pictures like this are not that easy to get according to the equipment you have and the patient's body habitus and when she last emptied her bladder, and et cetera, et cetera. So it's simple, but it's not. Prescribing progesterone turns out to be the hardest part of this, to get it going right away. If you have presumptive eligibility of the woman who says she's pregnant, you're way ahead of Ohio. We pretend that we have it. We have it for a couple of things, but it's not really in practice. It's supposedly approved, but it's not. It would be great if we did, because right now there's a big gap there. A management protocol, as I said, needs to be adopted, and you can have 1 or 2, 1 for each probably. And my eventual goal, I think, is to make screen for prematurity right up there with everything else that's got a checkbox on the prenatal care sheet. You screen everybody for gestational diabetes, you know their blood type, you're going to do a GBS at a certain point in pregnancy, etc. Let's put it on very soon. The first visit, maybe the second visit if the patient comes in before 10 weeks. You ought to know what you're dealing with historically by 14 or 15 weeks, because you're either going to do cervical lengths because of a history of previous premature birth in order to decide whether she might benefit from a cerclage based on her history and progesterone treatment, or you're going to do a screening ultrasound exam later on. So you have to put this on your form. This is an amalgamation that's in your handout so that you can see what we did at our place to put the 2 protocols together. It starts at the initial prenatal visit with ultrasound confirmation of dates and a history, and then you get into is there or isn't there a history, and on the no side there's no history. Whoops, I went wrong. On the no side where there's no history, then you have to make a decision somewhere here in the middle. Are you going to screen everybody or not? Do you do that or not? If it's a twin gestation, it's not there. So this is kind of for your later use and debate if you want to use something. Administrative barriers, we've made a lot of progress in central Ohio around this. Talking to the pharmacies, talking to insurance directors, medical directors of managed Medicaid, Ohio Medicaid, the senior medical officers of Champus. People have the idea that only the manufactured form of 17P is the only one that's legal or available. That is not the case. Yet compounding pharmacies, some of them do a good job, most of them do a good job. So if you have one that you can trust and learn about and have them attest for how they get certified, you can use compounded 17P or compounded vaginal progesterone suppositories. If not, maybe you'd rather use Prometrium, which is a manufactured drug for oral use that can be given as a vaginal tablet or capsule, and has been studied in one of those studies and works pretty well. What it boils down to is having a plan and talking to the people who are in the process, and probably having we call Hetty Walker our progesterone queen. Probably progesterone coordinator is a better, more professional phrase, but you need somebody who can handle. People can't remember this stuff. There's too much. Too many places you can bump into the wall and not get anything, and the next thing you know, you missed your chance. So having a progesterone, especially for a quality improvement effort, having a progesterone champion or coordinator who can be the information resource and the one who cuts through the stuff to get it done. And then having people talk about how they did and what's happening at your place. A lot of crosstalk really helps. Somebody solved the problem that you can't solve. That's really where QI comes in also. Here again, this isn't for you to look at except to say in order to solve this and make it somewhat easier for our referring sites and our docs and nurses at our own places, Hetty and Tammy, our two prematurity nurses, put together this data form, which is probably a little out of date, of various suppliers. SBH is the compounding pharmacy, some of the other places, vaginal suppositories, 17P, how much it costs, what the dosage forms are, that kind of stuff, that needs an update. But that sort of information ought to be handy. So how about the outcomes? How will we track the outcomes? Well, the good news here is that the outcomes are already being tracked. Dead babies and premature babies are what your state already records. Maybe not accurately, but this is a big deal. We're going after the big bad guy in OB. And so this is what we should expect to move. My own sense is that we may not move the 37-week line much because a lot of the personal experience I have is somebody who delivers at 32 instead of 28, that kind of stuff. But I think we might be able to move the 32-week line. If we can do that, nothing else could possibly do that. There isn't any intervention out there that has a chance of affecting the 32-week rate, which has been unchanged. So we ought to look at that, and we'll look at it in raw numbers, look at rates, look at various regions, look at NICU admissions, perinatal mortality rates that account for stillbirth. There is always some concern about if the baby is stuck in a bad place, wouldn't progesterone prolong the pregnancy so the baby would have more chance to be stillborn? That's a theoretical fear that fortunately has no confirmatory or suggestive data at all. But it's a signal. You have to watch the stillbirth rate, just like with a 39-week project. Make sure you're not forcing pregnancies to go beyond where they should and seeing a rise in stillbirths. And so we have to worry about that for progesterone, although I don't think we have much reason to worry. We have to worry. And we should look at infant mortality rates as the ultimate outcome for OB. Infant mortality rates need to be linked to OB. We don't think that way in obstetrics yet. So how are we going to do this? Well, we're going to start calling the Ohio birth certificate the birth registry. I've been told that I should do that. So that's the birth certificate data. We'll have individual site data from both NICU and OB. We're going to collect data. I think I'm going to show you that on a different slide from all sorts of places. But one of them, these are kind of parallel outcomes. These are not the only outcomes, but outcomes in addition to the actual patients we're going to talk about. We should be able to see better things in all these various administrative ways. So processes along the way, we'll have hand-collected data at the hospital when a woman is admitted with prematurity-related problems. We'll ask the OB team to collect that, just like we did for steroids or something else. We'll ask the NICU when a baby is admitted may not have been delivered at our place, may be a transfer or something. We'll ask about that, and we'll particularly look at the clinics, the larger clinics associated with health departments and public health sites and academic centers. We're not going to try to peek into private doctors' offices. We're going to ooze and disseminate and seep into practice. We can count the number of cervical ultrasound exams performed, and we can look at these various other data points. So the big 20, the 20 charter hospitals is where we are now, and interestingly, now that OPQC is not brand new anymore, the smaller hospitals, the medium-sized hospitals in Lancaster and Chillicothe and Zanesville and cities you've never heard of, Upper Sandusky, places like that, they're starting to go, hey, wait a minute, what about us? We haven't even started yet. And when we did the other one, they didn't really hear about us till we were up and running. But now that we are up and running, everybody is interested in trying to not be left behind. So it'll be a management problem. Outpatient data collection, as we talked about before, is not easy to do. I'm not sure how we're going to recruit new outpatient quality improvement teams. The hospital-based ones, we already have those. And we only get this inpatient data about people that we missed or who were treated but not successfully, et cetera. We're not going to track any one patient all the way through the pregnancy. That's just not the way QI works. We're going to look at the problem from 3 different perspectives: clinic, maternity admission, NICU admission. So retrospective versus prospective. Somebody said, why don't you just capture it all at the hospital? Forget about it. Well, in this case, we could do that for steroids because that's a system that's already up and running. But for this, we need to affect and have an opportunity to change the outpatient steps. So we really need to collect data there to see what's going on. Otherwise, we would never be able to change it fast enough. We'd have to wait 6 months until after something happened. Here's an example of a form, a typical OPQC type form. This is a draft, not final yet. And we're going to try to collect some information. Why was the patient? This is just on women who are either considered for progesterone or who got progesterone. We won't really have a denominator. We'll just have an idea of approximately how many there should have been. Was it short cervix? Was it a history? If it was short, how short? What form did you find and prescribe for the patient? And what of the various obstacles, in particular the source of payment, and the same sort of stuff, simple stuff for the OB admissions and the NICU forms. So this is our systems approach to the original Big 20 in the 6 major areas, and we'll disseminate out to the regions, I think, faster than we expected. We have a Partners for Kids as a PHO of Nationwide Children's Hospital in Columbus that has financial responsibility for all the indigent children in southeastern, central, and southeastern Ohio. And they've partnered with Akron Children's, and they're going to try to disseminate this to the whole eastern third or half of Ohio while we're doing this. We're helping them, they're helping us, we'll see. And we hope we'll be able to move these rates. So to finish up, there's some definite pluses here. We have strong support. We have the governor on our side. We have the ODH on our side. We have vital statistics people actively involved. We have the Ohio Collaborative to Prevent Infant Mortality, which is a kind of a congregating group, an information sharing where the players in infant mortality all meet about 3 or 4 times a year. We have a good track record. We have what I would call a collaborative Midwestern spirit. People are saying, okay, I'll do that. You know, we're not New York. I always think of, I like to go to New York, but it always seems that they're arguing about things there. We don't have as much of that in Ohio. Too cold. The minuses, though, are that it's brand new. That is to say, the guidelines, the benchmarks have only been laid down in the last year. Lots of uncertainties about it. We're doing it in a place for which there's no previous quality improvement project, the outpatient arena. The people who are going to initiate the progesterone do not necessarily see the adverse outcomes, And there's a long interval between action in the outpatient clinic and the outcomes we're looking for. So it's incredible what the energy that comes from doing the 39-week project and seeing the numbers go down within a 3 or 4 months. You know, we started in August and collected some data. September we met and decided what we were going to do and started collecting data. By October we could see the numbers going down a little bit. By December it was like, yay, everything's great. By January you're like, can we publish? You know? No, you can't. But anyway, it was wonderful. That is not going to happen here. And we're going to worry about it and agonize over whether we're doing something. We will not know for about a year. So our goal is to do all that stuff. This is just kind of like the summary slide to make sure I didn't forget something. We need to train the workforce, and we need to get the payers on board to pay for this kind of stuff. And I think that's going to come. I think that'll happen. And I hope we really move that 32-week line. And that is the end of that. So I have a little bit of time for questions. Maybe I should back up, turn the lights back on from there. Yes? The question is about have we considered any studies on the effect of progesterone on the ability to bring milk in. That is a concern. What we're considering doing, although we're not really doing any studies, this is all QI, so it isn't really research. What we've talked about in that regard is to, as part of the progesterone promotion package, to advance a milk is medicine approach to these women with a previous preterm birth or short cervix. You are at risk of having an early baby. If you deliver early, your baby's doctors will want you to provide breast milk. You may not want to breastfeed yourself. That's up to you. There's reasons to do that. We'll let somebody else talk with you about that in a minute. But right up front, if your baby is born early, you will need to provide breast milk because it is medicine for your baby that can be obtained nowhere else. So that's one step in the direction of recognizing that. Another is that some of our sites are academic centers where they're actually going to try to study that as a research project. But OPQC is, and your organization, you can publish what you've done, then that becomes research. You have to have IRB approval. But as long as you are just, at least my understanding of the rules, improving outcomes using existing clinical practices and looking at your own data and collaborative data, you're allowed to look at your own data and use that internally to improve care. So that kind of thing could be done as a research project to track the difficulties in milk production in women who were treated, but it would not be part of the QI system. Yes?
As background, I work in a federally qualified health center that's at least an hour from the nearest hospital or maternal fetal medicine office. My women, mostly 50% of them don't have any insurance at all, and transportation is a big issue for them. So what I'm considering doing is putting together a protocol that instead of using ultrasound to measure cervixes, would use cervix. And because it's easily obtained, it's something that you can do in the office. It's been proven by studies to be pretty...
Stop right there.
Yeah, well, I know, it would help as a screening to know who you
Yeah,
can do
well, your question brings up the issues of being remote from a big center and how are you going to do it. One would be to think about the Prometrium vaginal progesterone choice for any patient who qualifies for progesterone in your site, because it's the only thing you could get pretty simply, so in terms of what drug you would use. So I put that on the table. But as far as what you really bring up is the issue of, it's really difficult to imagine doing transvaginal ultrasound on lots and lots of women in many, many places in the United States. So what are the options for trying to figure out how to reduce the need for that and the cost of that. And there are several options, and none of them have been shown to be satisfactory yet. The hottest one of the moment is transabdominal ultrasound of the cervix, which is got a sketchy history because you have to have urine in the bladder to see it in many women, and the urine in the bladder creates an unpredictable effect on the length of the cervix. So seeing it can mean that you're measuring the cervix, but you're also squishing it with mother's urine, and you can't measure the urine and control for that. However, empty maternal bladder and transabdominal sonography of the cervix is possible in many women. And so papers have been published recently that suggest that that might be a way to eliminate as many as a third of the women who might otherwise have to have a vaginal ultrasound, if that's what you're judging it against. And the threshold is uncertain. It's probably going to be 35 or 40 millimeters, not 30, 35 or 40 on a transabdominal scan. Another way is digital exam. That has been studied a lot and is just, it's operator dependent. Your fingertip is my 1 or 2 and et cetera. Same for percent effacement. It's all basically, that's not a good way. So what about surveillance? I like Dean Cook a lot. He is the president of surveillance, and I wish him well. I've known him for a long time. I have told him right at the beginning, I don't think it doesn't make sense that a product that measures, if you don't know what it is, it's a little slide device that on a speculum exam has a stop at the outer portion of the cervix and then a slide that goes up into the lateral fornix of the vagina. And when you meet resistance, you stop and twist it, and then you pull it out and look and see how long was the cervix in the lateral margin of the cervix. And the studies that have been done of that are not many. Those that have been done are not large. And the ones that we did, unpublished, we were not able in a large number of women, literally hundreds and hundreds of women, to create any correlation between the cervicalens measurement and the cervical length measurement. So I think that makes biologic sense, really, that they don't correlate because the length of the cervix is the length of the closed portion of the cervix. As appendicitis or strep throat, you don't really know if she's got an elevated white count or an elevated temperature, but you do know that something's not quite right. It's a marker, and it isn't right next to. So this device could it certainly hasn't been shown this way yet, it could measure something that is vaguely correlated with short cervix without actually measuring the cervix. But the data around it is way, 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 yeah, preliminary is the word I was looking for. They'd like it to be better, but
I'm mostly looking for who I really have to send it and I don't, because it is such a burden for my patients.
yeah, well, I think transabdominal might be an easier way to go, or selective. Make yourself a list if you have an at-risk population of risk factors. You look at your entire population, you may say, you know what, 80% of my people I take care of have one or more of these risk factors. I'm trying to find the 20% that don't. You know, I don't know about that. If you wouldn't want to rely on some of these screen tests as diagnostic tests, just as screen them out. So it really would. I start with looking at your population. Right, Jerry, is that you? I think I have to go pretty soon. So this will.
I would just comment on the last speaker that I think one of the beauties of an organization like this is if you were in the USF sphere, which is my place, I'd love to sit down and talk with you, and I would presume other academic centers to figure out how we can collaborate, because all of our goals were just reducing preterm birth, and are there solutions where we come to your patients, your clientele, because we also understand they can't travel, and maybe that can come up in the breakout session, which I'm excited to moderate with Judette. I thought you gave a great presentation. I thought your most impressive visual slide was that graph with the drop in preterm birth rate. Having listened to presentations yesterday and seeing drops like that almost immediately how your drop was over years. Could you comment on whether you feel that the rollout, which was not in the context of the kinds of things we're talking about, accounts for that, that the rollout was over years, so the data makes sense? And the reason I ask that is your drop seemed to be in excess of what some of the studies predict that progesterone would affect, and many of us have been dealing with this undercurrent of question that the number of NICU babies is dropping, but none of us seem sure why, and your time period overlaps that. Is that coincidental, and is something else in the air or the water?
Yeah, you're right, Jerry. It very well could be something else entirely. We looked at this data every which way, and we're finally able to look at it because we acquired a perinatal epidemiologist who could crunch the numbers for us, and we looked at all the potential confounders about population and other things we could think of, and we really couldn't think of anything else. I'm not really sure what we would have done. Our population is heavily dominated by women who would be not O'Brien patients, okay? If somebody comes to us with a history of a spontaneous premature birth, and it's a little uncertain whether it really was spontaneous or not, we will withhold progesterone if they'll come back every week while we watch the cervix between 15 and 20 weeks of gestation. And if it starts out at 38 and it just stays there, those women are graduated out of our clinic. So we're focusing on what is largely a progesterone-sensitive group of patients by just demographically who we take care of, and by some of our practices. We just feel like we can't take care of somebody whose risk is not amenable to what we know how to do. So anyway, thank you very much for your attention. It's always fun to talk about.